It's Speaking with Gravity. On this podcast, we talk about mental health and how everything affects everything. With every episode, the goal is to have a conversation that will make you think, make you feel, make you do what is best for you. This isn't therapy, it's a podcast.
Welcome back to Speaking with Gravity. I am one of your hosts, Kervin.
Hey guys, I'm Hannah.
Hi, I'm Montrese Carrington.
And today we are going to talk about diagnosis. Yep. And tell the truth about different diagnoses that we talk about when it comes down to mental health. Everybody feels like they know what they're talking about. Or even if they don't feel like it, they just kind of throw these words around. Oh, you bipolar, or well, I don't hear too many people say you schizo, but you know, you definitely hear bipolar a lot. Even when and I should not do this because I'm a therapist, but my brother's a Gemini, and so I always pick at him and tell him he bipolar. I should not do that, but he's my brother, so
you can do that.
Yeah. We do that amongst ourselves. So to get into the discussion for today, we're gonna do our QD of the hour first to kind of set us up. And QD of the hour is just another version of fun facts. You know, we talk about mental health, so maybe you'll remember our QD of the hour and go present it to somebody one day.
Right. Okay, so our QD of the hour. Bipolar is one of the most frequently misdiagnosed mental health issues. Somewhere between 1.5 and 6.4% of people worldwide are affected by bipolar disorder. However, it's hard to say which number is more accurate due to the frequency of wrongful diagnosis. One study found that 69% of people with bipolar were initially diagnosed with something else. Approximately one-third of those individuals remained misdiagnosed for at least 10 years. And our source is higherpower.com.
1.4 to 6.4, so anywhere from 2 to 7 people out of 100. But the way we throw it around, you would think half the people in the world is bipolar. But that's neither here nor there. Montrese, can you kind of tell us about your background, how you got started, how you got here? What made you get to this point? Decide on this career? Did this career decide on you, or you decided on the career? So just give us a little bit of background on you. I've seen you on social media. We did a podcast together. I don't know you personally, but you have a wealth of knowledge just from my interactions with you. So just kind of give us a background.
Okay, well, I started out as a nurse. I was a nurse 20 years, and I decided I wanted to do more, so I went back and got my adult gerontology nurse practitioner. And then I got interested in mental health because I kept seeing a lot of like my hypertensive patients and my diabetic patients who were not controlled. And when I would start talking to them, I would learn that it was something deeper going on. And then my daughter, she went through some mental health issues on her own. She's bipolar, and I wanted to help her. And I had a hard time trying to find therapy for her, a psychiatrist for her. The waiting list was ridiculous. So I started digging in, studying. I became interested in being a mental health nurse practitioner, so I went back to school for that about 2 years ago.
Okay.
Yes.
So you enjoy it? You like what you do?
I love it. It's stressful, but I love it.
So I know you mentioned your daughter being bipolar, and we led in with the QD of the hour. All right. And told y'all, I gave my confession. I was transparent about me laughing at my brother, picking on him for being bipolar. But what is bipolar? Break it down in your terms, what it is for her.
There's a bipolar 1 and 2. With one of them, you have mania episodes where you like feel I'll say real high is how I will describe it. And then you have the depression where you feel real low. And you cycle between the two. And it is mixed diagnosed a lot. I have seen a lot of patients who come in to me because by the time they get to me, they've already been through the therapist, and because I do the medication aspect of it. and it's only 15 minutes. So the bulk of it, I will say, comes from the therapist.
Okay.
And I see depression tagged to a lot of people. And the problem with that is if they are bipolar and you're treating them for depression and you give them a SSRI, something like Zoloft, you're going to send them into mania.
Now, you said SSI. People
If
don't
you
know.
give them something like, let's say,
what is S?
it's
what is-
a antidepressant.
Okay, all right.
But with bipolar, you have to treat it first with a mood stabilizer. You
Okay.
can't just jump into antidepressant, because if you do, then you're going to send them into mania.
Because you want to stabilize their mood.
Right.
They going in between
Right.
the different moods, which that's
So-
important for people to know.
Right.
Yeah.
So you have to have the mood stabilizer plus the antidepressant. It works together.
Just from you giving medication, and we're gonna get back to bipolar, but how would you suggest that people advocate for themselves? Like, if a medication isn't working, specifically with psychiatry, if a medication isn't working, how do they advocate for themselves? And they might not know that, all right, I'm being misdiagnosed, but they know that they just don't feel right. So how do they advocate for themselves?
I feel that it starts with them talking to their primary care provider. And I even tell them, because we only have like 15 minutes to get in there, and is your medication working? I said, don't hesitate to slow me down. If I'm going too fast,
Yeah.
if it's something that you need to tell me, you're going to help me treat you. So slow me down. Tell me you feel different. Tell me, if you're feeling worse. Just tell me how you're feeling. So once I get patients to open up to me, and I let them know that I'm human, I understand, and I'm not just pushing numbers, they'll tell you,
Exactly.
if medication is working or not.
All right, so getting back to bipolars, it's going between highs and lows. Anything else? Was that bipolar one? Which one you was explaining to us? Or
Both 1 and 2.
Okay.
Kind of flip between.
is there a major difference between 1 and 2?
With the bipolar 2, I would say patients stay in the depressed mode more.
Okay. All right.
Bipolar 1 and 2 patients can have depression, but they're in bipolar 2, you see them in the depressed mode more.
Yeah. You said it's misdiagnosed. Have you seen where it's something else that they typically diagnosed with instead of bipolar?
Yes, depression,
Okay.
anxiety. I think that's this label that we
The
put
initial-
on everybody,
yeah,
because
yeah.
like when you come into the doctor's office, because I do primary care as well, the nurses will give like a PHQ-9 where it screens for depression. They don't have anything to screen for bipolar. They don't have anything to screen for the other diagnosis. They just have depression.
Okay.
And I just want to add, there is another newer condition called disruptive mood dysregulation disorder, DMDD, and this condition is often misdiagnosed in children. So, of course, it's a newer diagnosis, and it's a lot of research going around that a lot of kids have been diagnosed with bipolar, but they actually experience DMDD. So, if you all feel the need to research that diagnosis a little more, then definitely do.
Right.
And when you said PHQ-9, that is Patient Health Questionnaire.
Yes.
And
yes.
it's just giving you
Screens for depression.
Yeah, the screens for depression and anxiety too, or just depression?
Just depression.
Just depression. Okay.
For anxiety, they use a
GAD?
scale, GAD-7
Yeah.
is what they use.
Okay.
And speaking on what you were speaking on, a lot of children are labeled as just being bad, disrespectful, and I feel like when they label with that, then they're going to miss the help that they need.
Yes.
Because then we're going to tend to discipline them the way we were brought up, and that's not what they need, some of them. And if they don't get the right treatment, they're going to grow into
Pattern.
adults with,
Yep.
yes.
I'm glad that you highlighted that.
Yes.
That if we don't assess and care for the condition up front when we see those red flags or when we see those different symptoms, that condition can progress into something to a more severe condition.
Right.
And it's when you say that about kids and parenting, you may have to parent differently once you take into consideration a particular diagnosis. And when it comes down to bipolar 1 or 2, when we're talking about families, what is something that you would want to share with families on how to deal with someone who has bipolar 1 or 2? Just in, not necessarily a specific problem, but just in everyday life.
That's a good question.
It is.
I tell my family members who are dealing with someone who has, they need therapy themselves, because they have to be trained on how not to react and how to react, because you can make it worse. So like with me, when my daughter is going through her moods and she's just real irritable, I know to back. My parenting, she would get her behind tore up. But I know to just, from working with it, to just kind of leave her alone, back. And both parents, I teach parents, especially with children, it takes both parents. I feel like they have to have a strong
Support system.
Support system is big in general anyway. So going on to schizophrenia. Can you kind of break that down in your own way? What that is, what we're looking for when we're talking about schizophrenia?
Okay, I will like to say that most people think that schizophrenic patients are violent.
No.
That's a myth.
Yeah.
Most of them not violent. I will say it is one that's misdiagnosed as well. It's not, people say that they have like double personalities, or it's not that either. They just have real distinct, without going into the DSM-5 criteria, they just have real distinct features.
And with the parents with them, the same thing, providing the support system for them, and knowing how to talk with them. One of the things that stands out for me, without going too much into it, when we're talking about someone with schizophrenia, I always look at, they have a reality that might not align with ours, but it's their reality.
Right.
And when you start trying to debunk or trying to tell them that their reality isn't real, that becomes a problem.
Yeah.
Right.
Not to say that we should, I don't know what word I'm looking for, but not that we should kind of, I'm trying to think of the word.
Like push it on. Or,
Push it on and say, oh, it's okay. You can. Not that we're just enabling them.
Yeah.
Not that we're enabling them, but that you're gonna create a bigger fight when you try to prove to them that their reality isn't.
It's not true.
You know, oftentimes when I've dealt with them in therapy and outside of it, I ask a lot of questions, just a lot of questions, trying to get to the root of, okay, why are you thinking that this is reality?
Right.
Where is this coming from? Does it always end up in some type of great big light bulb went off? No, but it does give them actually validation that I'm listening, that I'm hearing. Sometimes they might get frustrated, but most of them are like, oh, okay, this person is really listening. They really want to know. They really want to understand me.
Right.
So yeah, schizophrenia, and I hate too, oftentimes when people get to the point where they look at schizophrenia and, like you said earlier, they try to make it one of those things where the person is so violent, so aggressive.
That stigma.
No, they not aggressive. They not violent. You know, that situation might have caused them to get angry,
Right.
and they might have got to that particular level. But all in all, and overall, no, they're not. They're not at that situation.
Right.
Do you see often, like how often do you see the schizophrenia, the bipolar? Or is it like, with what you do you see a lot of different people, with a lot of different diagnoses, or is it your concentration on one or two things?
Bipolar, I see some schizophrenia patients, anxiety, depression. I will say, back to the schizophrenic patients, we have to be aware that some have hallucinations, some have delusions.
Yes, I forgot about that.
And not that we're going to talk to them and make them, we don't want to, how can I say this? It might be real to them.
Yes.
We don't want to encourage them, like if they say they hearing things, we don't want to say, well,
That's not true.
Right, right, because it's real to them.
To them.
Yeah. All right. So what about? This is one of my favorite. one of my favorites, narcissistic
Oh, wow.
personality disorder. And the reason I say it's one of my favorite because people is, oh, you're a narcissist. I don't know about that.
Right.
Can you kind of give us a backdrop or background on that?
Yes, and it's kind of floating around social media.
Yes.
And I think that everybody who's been in a bad relationship, they label the person, oh, they narcissistic. And to be honest,
Can you say that one more time for the people in the back? Everybody that's been in a
bad relationship, they label them as narcissistic.
Yeah.
And to be honest,
sometimes you're just in a bad relationship.
just in a bad relationship. And I hate to see that word thrown around because it is a serious, mental disorder or illness. And I feel like some of the symptoms of thinking highly of yourself, we're supposed to think highly of ourselves.
You're supposed to be confident.
We are. But I will say that they can be very manipulative.
Yes.
That is a key sign. The manipulation is real.
Yeah. And manipulation. Would you say control?
Control, yes.
So, yeah. And then confidence and just
Being deceitful, lying.
yeah. Yeah. But that don't mean just because somebody deceitful that they narcissistic.
Right.
Right.
Or they confident that they narcissistic. What? Let me see here. What I got written down here.
And I also like to add that just to feedback off of what you said, that some people can have those negative characteristics, but that doesn't make them narcissistic.
Right.
They can have poor characteristics where they may be a little controlling in some aspects, but we're talking about a serious mental health illness of a person that does this routinely in every relationship they deal with, not just in a romantic relationship, but maybe in a parent to child relationship or in a sibling relationship or even coworkers,
Right, on the job. That's a major one.
This could be opinion based, but can a narcissistic person have a healthy relationship? And this is not, we're not talking evidence based.
I'm going to say yes, they can. I believe the key to is controlling the symptoms and that therapy, that cognitive, the CBT. I feel like that therapy is important because when somebody wants to do better, they can be taught to do better.
And I'm glad that you mentioned that internal desire. If a person is narcissistic and they don't see themselves as a narcissistic person, or they don't see anything wrong, those patterns might continue. But if you have that internal desire to change and to want a healthy relationship, that's where it starts.
Right.
You have to actually want that and work towards it.
In grad school, I actually wrote a paper on narcissistic personality disorder. And y'all forgive me, I called Kanye a narcissistic. I said he had it based on the way I wrote the paper. Now, I don't really still think that. I do think he has some things that comes out as narcissistic. Yeah, but I don't think he has it now. But, we have to be careful. And this is why people don't like labels. Because when you put labels on people, then there's certain things that's associated with that label. I used to say all the time, some stereotypes are true, right? So you label this person, they become a stereotype. Now you're putting them here.
Yeah.
You're putting them in this little box and saying this is who they are. At the end of the day, we're still individuals.
Right.
That's what we need to say. We need to think about first. And then secondly, we need to be careful about just taking what social media is saying, just putting it on somebody. And then sometimes people can become what you say to them all the time. You just keep throwing that at them. They're going to mess around and just start really behaving in that manner. Anxiety.
Can I go back to that bipolar one for children?
Yeah.
Like for parents, I know when I was trying to get help for my daughter, I want to encourage parents to not get discouraged. Because like you say, they don't want to just stick a child at a before a certain age with a certain diagnosis like bipolar. You can't just do that because once you label them as such, it's going to follow them.
Yeah.
So that's very important. I'm glad you mentioned that.
And also, when you were saying that about it was hard to find a therapist, sometimes it's hard to find a psychiatrist. Hard to find don't mean impossible to find. It's just being consistent and persistent.
Yes.
Obviously, you know, I'm out here. There's other people out here, but you gotta know who to look for, who to talk to. Don't be scared to talk to people that you actually know. I'm pretty sure you have a big circle. You might not be able to see that person, but you know somebody that can see them.
Right.
So utilize, for anybody that's listening, utilize your resources. Talk to people who are in the field, who can lead you in the right direction. And there's so many people, as often as I say this, it still seems like people don't know. You can go to a website called Psychology Today that has all the therapists, not all the therapists, but a lot of therapists go, and that's a directory of therapists. And in that directory, you can see who has a specialization, if they have one, who completely and totally deals with this particular population, which is what you want ideally in anything that you're going through mentally. If that person, if that therapist usually sees those type of people, then they're going to be the most benefit. Well, you would think that they would be the most benefit. But Psychology Today is one of them. Therapy for Black Girls is another website that you can go to find a director of therapists. Therapy for Black Men. There's Open Path Collective that is out there. And it's a couple of more that won't come to my mind right now. But on those websites, it has not only the therapists, but psychiatrists too. So you can find them is what I'm trying to say. And then what else I was going to say? I was going to ask you a question and it just left me as I started talking about that.
That's okay. I will like to stress, a lot of patients, like when they go to therapy or when they meet the psychiatrist, if they didn't have a good feel, they're kind of hesitant about going back. And I try to encourage them to go back or ask for someone else, because everybody's not going to be the fit that you need, and you have to feel comfortable with the therapist or your psychiatrist, because if you don't, you're not going to listen to them. You're not going to be able to establish that relationship and work together.
That they say one of the most important things when it comes down to the success of therapy is the therapeutic alliance, right? What kind of bond you have with the person that you sitting across from? Do you trust them? Do you believe in them? And then, you know, like you said, can I believe in them? Have they built up enough rapport and credibility where, you know what, I actually want to I want to listen to what they got to say. I want to implement that into my life. So before we end, I kind of wanted to talk about like anxieties.
Okay.
Is there anything because that's a real broad, it can be really, really broad.
Right.
And as you alluded to earlier, it's like typically when people come in for the first time, you can slap, I shouldn't say it in that manner, but you can just slap this diagnosis on them. But they can meet the criteria for general anxiety disorder, or they can meet the criteria for major depressive disorder.
Right.
So, in general, what would you like to give with regards to anxiety?
Anxiety, I feel like that's a diagnosis that a lot of people don't understand. And if they have never experienced anxiety, especially with the GAD, it can feel like a heart attack. I know from personal experience, but it can feel like you're having a heart attack, and they're going to rule out everything cardiac first, but it's real. And don't just, brush people off because they have anxiety. So I have learned to really listen to my patients. If, say they come in and their blood pressure is 2 points low and they have anxiety, that's major to them. I don't downplay that.
Do you have, so when they're coming into you, they're already diagnosed at that point, right?
Pretty much so. And that's because the psychiatrist that I've been working with, he's been at the practice longer than I have. So I am pretty much getting the ones that's already diagnosed. I do have some that aren't diagnosed, and I had my own practice for like a year, so I did a lot of diagnosing with that.
Now, do you have like, Do you give medication, or do psychiatrists, not you, do psychiatrists give medication based off of the diagnosis or based off of the individual, if that makes sense?
Most give it off the diagnosis. I'm going to tell you how I do it because I'm not comfortable. I'm not saying that I don't trust the diagnosis that they come in with, but I have to talk to them myself at least that first time so that I can make sure I'm giving them a medication that suit them. For example, say someone comes in, because I do primary care as well, and they have migraines or they have back pain, the sciatica, but they also have, depression but I try to give them something that maybe can help both, like with gabapentin, black box. You can treat it, you can use that for headache. So I try to give them that and just document why I am using it, black box, so I can treat both.
Focusing on those person-centered symptoms versus looking at the overall diagnosis and saying, this is what you need. Yeah, I like that approach.
All right. So, anything you would share in general? Any parting statements you would want to give about any of those things that we just talked about? Anxiety, narcissistic, schizophrenia, the schizoaffective, and bipolar 1 and 2.
Do not be afraid to ask for help. Don't be afraid. Don't think that just because, say, you put on medication, don't think that just because you started on medication that you're going to have to be on it for the rest of your life. And it's okay not to be okay.
Yeah. It's okay not to be okay. Not okay to just stay there.
Right.
There are a lot of people out here who want to help, who are trying to help. Find those people, those people around you, put them in your life, so that you can get to where you want to be overall in life.
Right.
That being said,
can I say one more thing?
No, you can't say nothing.
I
You said
can't
you.
say one more thing.
No. You can say something else. Go ahead.
I want to also say that you can believe in God and still seek mental health help, because I always tell people when they tell me I talked to the preacher and I talked to this person, that person, church, that's fine and well, but speak to someone who's certified, who has the training to help you. And I always tell them faith without works is dead. So God put people in different places for different things.
You got to do the work.
That's right.
Most definitely. And we out here. Those people that you can utilize beyond just your spiritual network. There are other people out here that can help you along the way. All right. Subscribe to Speaking with Gravity on Facebook, Instagram, Threads, and TikTok. And check out if you're a man and you're looking at this, you're listening, you want to know more, maybe we'll get you to come down here again at a later date.
Okay.
But I do a BIPOC wellness group for men, men only, on the 4th Wednesday of each month. So, if you're a man and you're listening to this, you can check in with us. But it's got to be in person. I don't do the virtual thing because I want the privacy to be there. So check that out. Shout out to Mr. Winston, who is behind the camera and recording us and producing everything so that we sound really, really, really good when you're listening to us in your car. You want to tell them how they can find you?
Okay. I work at Sand Hills Medical Foundation. We have like 5 offices, but I'm based in Lugoff. So just type in Sand Hills Medical Foundation.
And if she is booked, I always tell people this too. When it comes down to it, if it's 3 months out, if it's 4 months out, just go ahead and set the appointment.
Right. Go ahead and set it.
I would rather you set the appointment than for you to wait 3 more months and 4 more months and then try to find something. It's not going to happen like that.
Right.
So go ahead, set the appointment now. You can try to find something in the meantime, in between time, but just go ahead and set the appointment. If you don't, then now you got an appointment 3 months out.
Right. And I will tell them, even if they get an appointment 3 months out, I tell my patients to call each week because people are going to cancel, people are going to no-show.
Very true.
And sometimes you can get the provider to double. I do a lot of double booking. So you can get them to double book to fit you in based
depending
on your
their
need.
severity.
Right.
Mhm.
Now, when you say double book, can you explain what do you mean by that?
Because, like with therapy, I think you all have like 45. How many minutes do you get? 30,
Anywhere
45?
from 45 to 60, depending on whether it's private practice. It depends on the provider.
Okay.
I do 50 to 60 minutes.
Okay.
But it can go as low as 43 minutes, actually, I think.
Okay.
Yeah.
So for me, their initial visit with me would be 30 minutes and then 15 minutes. Double booking would mean, okay, this patient really needs to be seen, so I'm going to see 2 in the.
Oh, okay.
To be honest, I'm going to work through my lunch break.
Okay.
That's what it really means.
Okay. So when you're saying double booking, like if I typically give somebody 15 minutes or 30 minutes, I would give you a double book. I'm gonna give you an hour, or I'm gonna give you 30 minutes.
I'm going to fit 2 patients in.
Okay, 2
is
patients.
what's going to be.
All right. Double booking means a little bit something different for therapy. That means I done put 2 people at the same time.
Oh.
That's what I was thinking at first. Like, I didn't mean to do that, and I have done that too. But I'm glad you said that about the booking too, because when they're talking to you, they're really giving symptoms of what's happening. You're taking it all in, and then you're giving them medication management based off of that, right? But when it comes down to therapy, you're getting that 43 minutes, that 60 minutes to work through those symptoms, to give you coping skills for those symptoms that are not related to the medication, to give you interventions to help with that's not related to the medication. It's really good to do both. I see where sometimes people will either just do therapy or people would just do medication management, but it's really, really good if you can do both, to kind of get the best out of your situation. That being said, thank y'all for listening to us, whoever is out there. Thank you, Montrese, for taking time out of your day to come and give this information that people need and want, actually. You didn't have to do that. This is not paid time, so you didn't have to do it. So I appreciate that. And the audience appreciate it as well. Thank you for listening. You could be doing anything in the world, but you chose to listen to us, and we appreciate that. Remember, this isn't therapy. It's a podcast.